Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with bilateral occluding earwax. We're just commencing with their left ear, which is the worst ear out of the two. You may have noticed this patient's got quite a hairy ear canal entrance. So these hairs that you're seeing on screen, they should only be located on the outer third of the ear canal, what we call the lateral cartilage portion. And that's because the cartilage portion of the ear canal is lined with a thick layer of skin, which contains three layers. The epidermis layer, which is the outer layer of skin, the dermis layer, and that's where the hair follicles are located, in order for these hair strands to be extruding out of the ear canal, which is now, as you can see, visible, and also the subcutaneous layer, which is a layer of fatty tissue and connective tissue. In the inner two-thirds of the ear canal, there's no dermis, so you won't find any hair follicles. Instead, the medial bony part of the ear canal, so the inner two-thirds, you just have that outer layer of skin, that epithelial, the epidermis layer of skin only, and that's the reason why you shouldn't find these hair strands. I know it can be sometimes annoying to see these hair strands because it can sometimes obstruct the view, but as you can see, it's not preventing me from visualizing and removing the wax. These hairs are actually quite important because connected to these hairs are the sebaceous glands, and the sebaceous glands secrete a substance called sebum, which contains loads of different fatty lipid molecules, so alcohols, cholesterol, squalene, for example, long chains of saturated and unsaturated fatty acids, bile acids. And so this lipid secretion, this oily lipid secretion from the sebaceous glands called sebum, that provides a thin protective layer across the ear canals, and it stops harmful bacteria and fungi from penetrating and growing in the ear canal. Also, within the dermis layer of the skin, you have the ceruminous glands, which is like a modified sweat gland, same sweat glands you find under armpits, and these glands secrete an oily sweat. So the other type of sweat gland is called an eccrine sweat gland, and that's more of a watery, salty sweat, whereas the sweat glands in the ear and under the armpits, it's more of an oily sweat. And again, that's got a high concentration of lipids, and therefore, similarly to sebum, it provides this kind of hydrophobic, oily, fatty, protective film that lines the ear canal to just provide a physical and chemical barrier. And because the nature of these lipid secretions are all acidic, and again, the acidity is good in the ear because it stops bacteria from fungi from multiplying. So that's why we got the hairs in there. The hairs, of course, also act as almost like filters. They filtrate the air, so any dust, pollen that enters the ear. It's been argued that the hair strands, the angle of them, help with the natural migration of wax out the ear to the ear. Possibly true, but excessive hairs, they can cause an obstruction, the wax to mat against it. So that's another potential cause of build-up of earwax. You can see we've cleared the majority of this wax. You've just got this sticky soft wax on the eardrum. It's matted, so these hairs shouldn't be there. So we know either the patient's been using a cotton bud, or when trimming their ear hairs, the hairs have flown into the ear. Now, that's the patient's eardrum. You can see a bit of scar tissue to the left, but where I've circled there, the eardrum is severely retracted. It's sucked in, and that bone you can see, it appears to be the beginning of the stapes or the stirrup bone. So you've got the hammer bone, which is the main bone attached to the eardrum. I'll come back to that in a moment. So this patient then performed what we call the Valsalva, and they were able to pop the eardrum back out, so that bone is no longer visible. But previously that eardrum was sucked in so much, it was retracted, that it was sucked in so much that it was attached to what appears to be the beginning of the stapes, the stirrup bone. So we have three bones in the ear. We've got the malleus, also known as the hammer bone. That's the bone that you can normally see attached to the eardrum. It looks like a shoulder or an elbow. It's a long bone which terminates in the center of the eardrum, called that the umbo. Then you've got the anvil, also known as the incus. So the incus has got two parts, and one of the superstructures, if you can see it on the eardrum, it should come vertically down, but I couldn't see that. So it's very likely that that anvil bone, the incus bone, some or all of it, it's become eroded, and possible reasons for erosion of the bones is through middle ear disease, so infections. Or it could be that when the eardrum sucked in so much, like it was in that patient, the eardrum constricts the blood flow, all the blood vessels, supplying blood and nutrients to the anvil bone, and that bone gradually, as a result, it begins to die. You get necrosis of the bone because it just doesn't have the blood supply. So that's another reason. So the patient on this occasion was able to perform the Valsalva to force air up their nose, up the eustachian tube, to pop the eardrum back out. But that's probably going to be a short-term fix. I have referred this patient onwards to ENT. They've never been assessed for a blocked eustachian tube. So the reason why this patient's eardrum is sucked in is behind the eardrum there's a tube called the eustachian tube, and that connects the back of the nose to the middle ear, which is the cavity behind the eardrum. And we want the air pressure behind the eardrum to be equal to the air pressure in the atmosphere, so in the ear canal, and that eustachian tube is responsible to equalize the air pressure. It's also a drain pipe, so any fluid behind the eardrum, it can trickle out of the middle ear through the eustachian tube. But if that eustachian tube is either blocked, so it could be blocked if it's just a very narrow opening, or the muscles either side that contract, which cause the eustachian tube to open, are weakened, or paralysis of the muscles, or it could also be there's congestion at the back of the nose, inflammation, mucus, which is blocking the eustachian tube. So the eustachian tube typically gets blocked at the back of the nose. If that's blocked, air can't enter the middle ear, so the eustachian tube is not able to equalize the air pressure. That results in a negative air pressure behind the eardrum because there's not enough air, which then creates a vacuum effect, a suction, a cupping effect, and the eardrum gets sucked in, like when you're on a plane. And so the eardrum gets pulled inwards, and then if unresolved, it can compress against the nerves. It can also affect your hearing. You can feel blocked. You can experience occlusion or autophony, where you can hear internal sounds, including your own voice inside your head. Give a fullness sensation, hearing loss, sometimes tinnitus, vertigo. Quite often, especially this time of year, patients attend the clinic believing that they've got earwax, and that's why they've got a blocked ear, but they've got a blocked eustachian tube, and that's due to nasal congestion and the eustachian tube becoming dysfunctional. So I've removed all that debris. I hope you enjoyed that video, guys, and the brief explanation of why this patient's eardrum was sucked in. Take care, speak soon, bye.